So I got the pleasure of introducing another friend from the East Coast. It's like East Coast Day today. I think Christian's on. Yeah, Christian's on. Christian Hall is a good friend. I met him in Miami at a resort. We were at Dentsply Sirona a marketing meeting or a removables meeting. I'm not really sure what it was anymore, but we met, and I'm like, "Hey, you're from Canada." Christian Hall owns one of the biggest labs on the East Coast. It's Hallmark Dental Lab. Uh, he's going to bring a viewpoint that I think is going to be really important to you guys as dentists. So we have a boutique style lab, four-man lab, Ben Muir, that just finished today with highly aesthetic restorations. And then you have Christian Hall. Christian Hall has restored over 2,000 CBTC planning cases in his career. He's also very knowledgeable. He's also employed a lot of my friends on the East Coast. So shout out to my friends on the East Coast. And I'm not going to really go into it further. My friend Christian Hall, you can take it away. Hope you can stay, everyone. Christian Hall.
Yeah, thanks, Mark. Thanks, everyone. Can you hear me okay? Yeah?
Loud and clear.
Good stuff. So thank you very much, everyone. Great job, Ben. Yes, as Mark mentioned, Ben and I are both from Nova Scotia. We're both very close to one another physically, and we're actually VP and president of our Nova Scotia Dental Technicians Association. So yes, we know each other very well, and I have the utmost respect for Ben. And he does as you saw, he does a fantastic job with his stuff. So it's a treat to watch you, Ben. And you're probably watching me now, so that's great. So I'm going to take a little bit of a different track here. Like I say, Ben showed some great stuff in terms of restorative materials and cases. I'm going to kind of dial it back right to the very beginning on implant cases where I think they should all start in the planning stage so that we don't get into trouble down the road. I know in the past, sorry, I guess I'll introduce myself. Yeah, I'm Mark already did, but Christian, Hallmark Dental Lab, Halifax. Yeah, full service lab, and we do a lot of everything, obviously. But my main focus in the lab is implant planning and treatment planning. So before we started getting into this heavily 4 or 5 years ago, I think all the lab technicians on the line and probably all the dentists on the line too have done an implant case where they went to take the impression and it showed up on our benches in the lab, and we're all like, oh no, what are we going to do with this? And that's never a good feeling to have, right? We always want to know what's coming down the pipe before we start. So I think the adoption of the CBCT implant treatment planning has definitely helped us out a lot in the last few years, and it's just getting better and better as people start to adopt it even more. So I'm just going to go through a few of the traditional guides, which are still used for some simpler cases, and then we'll get into the real meat and potatoes and the real benefits of the CBCT guides and show you guys kind of how beneficial it can be. So we'll go through some of the guide variations that we see in the lab on a day-to-day basis. Vacuum form, processed acrylic, light cured, and some of these are going to look familiar, some of them aren't. So most of the time they would get divided into two main categories: the prosthetically driven categories. The decisions are guided based upon the position of the crown. So this would be your typical old school guide, if you will. We put a tooth in there, we drill a hole in the model, and we give you something. The lab gives you something back where the surgeon can place the implants. That would be considered prosthetically driven only. Surgically driven only, decisions are guided upon the basis of the bone. There's no real guides for this. It's basically, the surgeon would flap the tissue, see where the bone is, and put the implant where the bone is. That's kind of the surgically driven approach. And then the combination, which really the CBCT guides take is the huge advantage of those, is that decisions are made on both the prosthetic and the surgically driven areas. So that's where the CBCT guides really, really shine. So in terms of the mainly prosthetically driven ones are the vacuum formed guides. So this is the typical one that we see. We don't actually see it very often because we don't make them in the lab that often, but this is the one that you would typically maybe make in your clinic. Very easily done by the dentist, the assistant, whoever. You put a tooth in the edentulous space. Sometimes I've even seen just a blob of wax or putty in that area, just something to hold the space. Then you do a suck down over that, and then you drill a hole in it. Right, so that's your prosthetically guided surgery. Mostly, like I say, done by the clinician in the clinician's office. And anyway, so the advantages of that, obviously, it's very easy to fabricate, and it's very inexpensive. So in most clinics, there's some time in the day that mostly assistants would normally do this, would have some time to spend the 10-15 minutes it takes to do this. So it is very inexpensive for the clinic to make on their own. The disadvantages is it's very flexible, obviously, depending on what thickness of Essex material you use. But usually you're using a very thin material, so it's pretty flexible. For a single implant, it's not bad, but once you start getting into multiple implants, it starts to become a problem. And the surgeon can unintentionally angle the implant, which we'll see in a second, and you can't sterilize it. So you can wipe it down, you can spray it and wipe it down, but you can't like heat sterilize it. I've had a couple come back to the lab and it's like almost a pool of plastic. They've tried to sterilize it. So this is what I mean by the surgeon can still unintentionally angle the implant. These are obviously very extreme cases. Many surgeons would laugh at this and say, I would never do that. But I've seen it happen, so just because you have the hole coming out of the center of the proposed prosthetic crown in the end, when you're in the mouth, it is easy to angle the implant in this manner. So these are definitely I would say my least favorite guides, but probably a little bit slightly better than no guide at all. And again, easy to make in the clinic, so they are used once in a while. This is what we would consider just a processed acrylic guide, which is probably the most popular one that we would make if we were to get a case that the dentist just wanted a regular guide, if you will. So same idea, we put the tooth or something in the space, indentulous space, and then we would wax up the wings, and then we actually process it. So this is hard, solid acrylic, and then we would drill the hole in it in the position that we think is in the proper position, knowing that we obviously can't see through the stone, we can't see through any tissue, so we're guessing as to where that hole should be. And so our guess is slightly better than somebody off the street. A dentist and a surgeon would have a slightly better guess than I would, but in the end, even the best surgeon on the planet, it's only a guess. There's no way to know where that bone is underneath that in that stone model. So it's still just very mainly prosthetically driven. The advantages is these are very rigid, so we can do these up to full arches for sure. It has the whole channel, so the whole channel is drilled all the way through, so it doesn't ensure the proper angle. It's very hard for the surgeon to go off angle. It's generally the surgeon's preferred guide versus a CBCT guide for sure. It's definitely more complicated than a vacuum form, so you'd see very, very few clinics doing these. Usually these would all be made at the lab, so it would add a little bit extra cost. For example, I think we charge $80 for these. I don't know, I'm sure all the labs around Canada are varied to some degree, but around 80 or $100, I think you would be expected to pay for one of these. And again, prosthetically driven only. This is a kind of a neat guide that I like. Actually, one of our prosthodontists uses these. He makes them himself in his office. It's just he just uses light cure material. It's very rigid. It has a partial channel, which we'll see in the next slide. So it does help the proper angle, and it's very inexpensive and quick to make too. This is actually the quickest one to make. You can bang these out in 5 minutes. So if you have a patient in the chair and you forgot or can't find your guide, you can whip up one of these pretty quick in 5 minutes, and you're not behind. So there is the potential to angle the drill buccally, which we'll see in a second. And again, it is prosthetically driven only. So to make it, you just drill your hole like normal, where you think it should be, and just get an old burr or a burr lying around, stick it in the hole, and put a little bit of crazy glue in there. Just glue it in so it's nice and solid. And then you just get some custom tray material, some triad material or whatever, and just basically, for the lack of a better term, squish it in, squish it around the burr, and then you throw it in your light cure machine and give it a little light cure. So one of the major advantages of this, I know some surgeons like it because especially on those patients that have a very limited opening, and if it's a tooth way back there, either a 6 or even a 7, they don't have to get the drill or the implant and the drill up and over the teeth. They can actually come in from the side, scoot in through the buccal corridor, if you will, and then just lay the drill in from the buccal. So for those patients with very limited opening, these actually can come in pretty handy. in those cases. And the only thing is they do have to make sure that the drill is resting on, on the back, because there is a tendency to, again, angle it slightly forward. So I have seen a couple of these being used, and they're still tipped a little bit buckle, because the surgeon necessarily wasn't making sure that they were back all the way. So again, something nice for those cases if a case ever comes up that with a limited opening case, they're really nice to use, and they're quick. So there's a little example of it there. So. And then we come to the, the CBCT guides. Those are the three that we generally see mostly without CBCT. So we'll go through the CBCT guides here. Very rigid, obviously. They're plastic, so they're rigid with the metal sleeves, which is great. The surgeons really love the metal sleeves aspect of this. It's prosthetic and surgically driven, obviously. So there's absolutely no surprises when we go to do the surgery. The disadvantages are the expense. If you want to look at it that way, they're definitely the most expensive, $250 all the way up to $500, $600, depending on what system, what implant planning software you use. They can get up to $600, $700, $800. But generally, I know at Hallmark we try to keep them as inexpensive as possible, so they can be as cheap as $150 in theory. And then the cost of the kit, if you want to do the full guide, that costs the money. The fact that you need a CBCT was an issue in the past more than it is today, and it's perceived as being too complicated. But I think once we get through today, you'll kind of decide that, or hopefully see that it's not really that bad. So in the past, when I say in the past 5 or more years ago, the barriers were quite high to CBCT guided surgeries. The availability for one, and the cost. I mean, even maybe 5 years ago, but 10 years ago for sure. I mean, you just couldn't get a CBCT, so it wasn't really possible. Even 5 years ago, they were few and far between and pretty expensive to get. Nowadays, I'm sure everybody on this webinar, either has one or knows somebody, or at least can refer somebody very close to get a CBCT at a fairly inexpensive cost. I know around here, they're anywhere from $150 to $250 maximum to get a CBCT, so it's not that bad. Software costs, if you want to do your own guided surgery in the past, yes, the software costs money no matter what software you choose to use. They're $5,000, $6,000, $7,000. So for most GPs out there who place a handful of implants a year, up to even 20, 25, even if you're doing 30, 40, 50 implants a year, the software still becomes sometimes limiting, a limiting factor potentially getting into it. And the software learning curve, the softwares aren't that easy to use. Once you use it a few times, it's not bad, but it's not the easiest thing in the world to become an expert on. And then the planning time per case. So I've kind of struck those out for this, because nowadays we'll go through kind of what we go through in our lab, and I'm sure there's a lot of labs around the country that offer the same thing. So as a general dentist, in my opinion, you do not have to worry about this. Besides sending the patient to get a CBCT, which would be your biggest concern. Learning the software, paying for the software, and planning the case is really not something that you really need to worry about. You as dentists have so much more to worry about, in my opinion, than having to worry about that. So, and which we'll get to. So we'll go through some collaboration logistics, and the fact that hopefully we'll see that this can increase some case acceptance and the cost as well. So most of these slides are going to be the DTX Studio implant, which is a Nobel product. I'm certainly not, this isn't a Nobel presentation by any means. I happen to use this software the most. I also use Simplant from Dentsply. But most of the slides you'll see here are the DTX Studio implant. So, but they're very, very similar. There's Straumann has theirs, and like I say, Simplant has theirs, and there's a whole bunch of other ones out there. Blue Sky Bio is a free one. So the things I'm talking about apply to basically all the software. So don't feel like I'm pushing this software at all. This is just, again, happens to be the one that I use and the most comfortable with. So all these softwares, they definitely enhance the diagnostic process, and they all allow each other to share between each other to give a better outcome in the end. When more brains that are involved in the case, the better the outcome will be. And it definitely supports the prosthetic-driven outcome that we all want, especially for the patient. And it also can assist in patient communication too. So for those of you who haven't seen CBCT guides, we'll just do a quick walkthrough here. So we would get the CBCT scan sent to us. and then we would load it, and or you would load it yourself. And then we would scan the model, or an intraoral scan for that matter, and a wax up. So you could send in models to your lab, and they could wax it up, and or you can send an intraoral scan, and we can mesh those two together as well. So it's very easy to do. And as you can see, we have the bone information here. We also have the prosthetic information here as well. You can see on the bottom left here, we have the CBCT in the bone. We have the tissue, the model, which represents the tissue, and then we have the wax up, which represents the obviously the ideal prosthetic spot for that tooth. And then we just put the implant where we want. So we select our implant, and again, just because I'm using Nobel software here, this software can be used for other implants, as well as every software out there, whatever software you choose to use or your lab chooses to use. You can usually pick any manufacturer you want. So then we just place the implant in the absolute best surgical and prosthetic position. So when we do this, like I say, we get the scans sent to us. Our clients, it's pretty well ironed out in our lab. So we would get scans sent to us. A lot of questions on people's mind when they first get started is, how I'm going to send these scans. We still get a lot of CDs actually sent in, mainly from the hospital, from the oral surgery unit, but other people send in CDs. But most of the time now we get them sent in. We can set up a OneDrive, which is easy enough, and any of the labs can do this. We can also use we use DTX Go, which was another Nobel product. So DTX Go, if you're a clinician, you can actually log into DTX Go. It's free, and you can actually attach the CBCTs, attach any STLs you have there, and it all is sent securely. So if you're somebody who wants to do things securely, which hopefully we all want to be as compliant as we possibly can, it's a nice option to send cases to your lab. And through the DTX Go portal, you can actually fill out the prescription. You can actually request a planning service. With Nobel right now, Hallmark happens to be the only lab in Canada that's on the list right now. But more and more labs will be added in the coming months for sure. So if anyone has any questions about that, we can talk about that. Have either send cases to us, or help your lab get set up with you so they can help. Yeah, it really becomes true prosthetic planning. So as you can see here, not only can we put the implant, we can actually put any kind of abutment we want on there so we know exactly what's coming down the pipe when we go to put the implants in and restore the case. So we're defining the optimal positions of the implants based upon the bone information and the tissue information and the prosthetic crown information. And again, we can also plan the multi-units on there, which we'll see in a little while, temp cylinders for temporaries, anything we want. So the software is very, very powerful. And there's a lot of softwares, like I say, that are just as powerful out there too. So it's really, and it's almost like when I hear back from my surgeons and the GPs who place, they've already gone through the surgery once, twice, 3 times virtually, right? So then when they get into the actual surgery itself, it does take a layer of, I don't want to say pressure, because most surgeons don't find too much pressure in placing an implant, but it does take a layer of just like stress, not even that they can perceive, but just at the end of the day, when they've done some surgeries with guided guides versus not, they just leave the day feeling like, yep, that day went great. Because like I say, they've already gone through the surgeries multiple times virtually. So there's literally no surprises at the end of that day and the end of the surgery. So we can see here, we can get either a pilot drill, or we can get a fully guided template. And so when we propose the guide, we can get the pilot drill, or we can get the full guide, which we'll go through in a second. And so this is the difference here for those who don't know. The pilot drill would give you a 2 millimeter hole in the metal sleeve for most of the implants, and we can get as small as a 1.5 millimeter drill if it happens to be a 3 millimeter case, 3 millimeter implant diameter case. The initial osteotomy is usually done by a little smaller diameter drill, so we can actually get really small pilot holes too for those really narrow implants. Or we go with fully guided sleeves. So as you can see with these fully guided sleeves, it's meant for all sequence of drills, all the way from the initial osteotomy all the way up as we step up with the drills, and you would actually place the implant through the guide, so it would be as close as possible to the exact fit as we've planned. So these types that you order from your lab. Yeah, and this is the difference between the pilot and the fully guided. So we in the lab, we would probably get, it's honestly probably 70% pilot guide and 30% fully guided. A lot of the guides we make are for surgeons all over. And the surgeons typically really like the pilot drills. They like to have gone through the plan virtually. They like to know that the implants they're going to be placing are going to be prosthetically in the right spot. However, they also like to have that just for the initial osteotomy, and they like to use their surgical skills to really place that implant the rest of the way. So in terms of popularity, the pilot drill is the most popular right now. And the fully guided is used, I would say about 30% of the time for us, depending on any kind of certain criteria. You can tell the difference in the kits that are required. The fully guided kit, definitely, if you're a GP, for sure, the investment would be a little bit more to get into the fully guided. So that's one thing that you'd have to decide, if you wanted to take that initial step to get into fully guided. There are a couple advantages to the fully guided, i.e. you can have, a screw retained temporary crown at the time of surgery. So we can plan the case. Not only can we plan the case and you can see the case, you can give your feedback, and we can get the implant in the exact position that you want. You can actually order screw retained temp too. So when you get the case sent to you, you'll have the guide and you'll have a temporary all ready to screw in. So that's a huge time saver for anybody placing implants, and it's a huge service to your patients too. So there are advantages to the fully guided guide. You just need to determine for yourself, which one makes the most sense for you. It's nice to have both options. So in terms of the communication, this is the main reason why I like it so much. It really does help to strengthen that the team that's working on your patient, right? When the dental lab and the surgical team, their storage team all start talking, that's when we get our best results. In the end of the day, that's what we all want for our patient, is they want the best results possible. So when they know we've all been talking about their case, they feel confident that they're going to have the best situation in the end. And again, with this software, it's all done through the Nobel Connect software, so it's all perfectly secure. So when just to give you an example, I'll get the case in, I'll set up the case. I plan the case, I get it kind of set up. I put it where I feel the implant should be based upon the prosthetics. And then I would share the case. I would share the case with the surgeon. I would share the case with the clinician. And then they would give their input. They would tweak it, they would change it, and then they would get it back and they would approve it. So I do set up the case. I certainly don't expect anybody to accept my plan on face value. In fact, I would never. I've had a few cases where the surgeon said, "Oh yeah, just make the guide." I'm like, "No, that doesn't work that way." So I set up the case, and the surgeon and the GP have to approve it. And then once it's approved, then we print the guide and/or and get the temporary crown at the same time. So, but again, it's all done securely through the portal. And again, all softwares have their different means of sharing the case back and forth. In terms of this software, excuse me, going back to you don't need to spend any money in the beginning for any software. You can kind of get, if you're somebody who hasn't started with this yet or just done a couple, it's a way for you to easily get into doing CBCT guides. You can send the cases to us or, any labs that you work with now that currently do this, and get the lab to set up the case for you. You approve it, and then that would be done through this viewer software. And again, all the softwares have their own ways of doing this, but you can see the case, right? So we would share the case with you. You see where the implant is based upon the prosthetics, and then you would approve it. So you don't have to spend any money on the softwares itself. Only when you're doing, enough implant and when you determine it makes sense for you, would you want to maybe spring the money on getting the software for yourself. And most implant companies have like a deal. You buy 15 implants and you get the software for free. So there's always ways to get it if you want. If you get to the point where you're placing and or restoring enough implants that it makes sense for you. One thing I do like about the Nobel software is that you can actually send a communicator file too. So the communicator is on an iPad. So if you have an iPad in your clinic, you can actually sit down with the patient and go through their actual case on the iPad, which is pretty powerful. So I'd encourage all of you actually to get the software. It's free, or sorry, the app. It's free, and as you can see, it comes with demo cases. I think it comes with 5 demo cases. And so even if you don't have that patient specific case loaded on your iPad, it's a good tool just to talk about implants in general, right? It's always nice to have models. You know, some people have a locator denture that they can show a patient to sell the case, if you will. I say that in quotations. This is like next level. This is like another step, I should say. So you can actually scroll through the iPad app, and it'll show different cases. You know, it'll show the difference between a partial denture and a fixed bridge, and then an implant bridge. So it does give you a great communication tool to get with your patients. And not only that, once you get a case planned with it, I can send you an ID which will load the actual patient-specific case. So if this was, you know, Mrs. Smith, you would bring this up on your iPad and you would go through a consultation with Mrs. Smith, your second consultation, and show her kind of what we have planned and what we feel like the next steps are. And you can annotate this, you can draw on it, you can, you know, show the patient how much time you've put into this. And you know, I say that, you know, there hasn't been much time really on your part put into this, but the team has really talked about it and decided on a plan. And when you sit down with the patient, even for 10 minutes, and scroll through the iPad and showing them their actual case, they're seeing their bone, their, you know, the implants in their bone, the proposed treatment plan. It's really powerful, and it definitely can increase the case acceptance for those patients that want to see that. We all know that there's patients out there that don't want to have any, they don't even want to know. They go in for an implant, they don't want to know what it is. They just want to get it in, get it done, get the tooth in their mouth. That's all they want. And likewise, you know, the other type of patient is like, let's say your engineer, who want to know every single thing about that case, right? They want to know what the coding is, what implant, what's the connection, what's the Morse taper, and all this stuff. It's those patients especially who would really get a huge kick out of this and really, you know, make them believe or make them understand that, you know, we're actually putting some real time to this case and you really care about the patient. So it definitely can increase the case acceptance by quite a lot. Just by doing this simple little thing. So it's really powerful. So, you know, to start the case, we were talking about before, but, you know, it's complicated. It's not complicated, really. For a partially edentulous case, it's very simple. The patient needs a CBCT scan, which, like I say, mostly everybody on this webinar right now surely knows where to send a patient for a CBCT. So they get a CBCT. You either load it yourself or you send it to your lab or send it to us and we load it. And then we just need a set of models. That's all you need, and or an intraoral scan. So, and those 2 things can be fused at any time. As we can see here, we get the impressions, we pour them up, and or we get the intraoral scan. And then we scan them on our scanner, and then we get a digitized version of that. And then when we get the CBCT scan, the software will mesh them. And again, all the softwares work the same. They'll mesh the models to the CBCT scan to get the prosthetic information and the bone information. So that's how it works. So it's very, very simple. For a partially edentulous case, you can send the patient to a CBCT whenever you want. You can get models whenever you want. And anytime in the future, we just mesh them together and then work on the plan. For fully edentulous cases, it's a little bit different. We get a fully edentulous CBCT scan in, well, we get them all the time. Once every 3 or 4 months, we'll get a scan in of a fully edentulous patient, and I have to call the doctor or the surgeon to say, we can't make a guide off this. Because for a fully edentulous case, we need to have what's called a double scan. So for a fully edentulous case, we need to have a scan appliance and or at the very least put some radiographic markers, radio-opaque markers on their current denture to send them for the scan. So when they go for the CBCT scan for a fully edentulous case, they need to have something in their mouth that you've given them to get the scan. Because what happens is if you just scan the patient with their current denture in the mouth, the CBCT scan won't see that. It'll see the bone, it'll see everything in the mouth, but it won't see the denture per se. And we definitely wouldn't be able to, even if it did see it, we wouldn't be able to mesh it in the software. So we need these markers, as you can see here, radiographic markers, to scan the patient. So when we put that in the patient's mouth and we scan the patient with it. You can see here, it's called the double scan technique, because we first scan the patient with the scan appliance and or the denture with the radiographic markers on there. So it'll see the bone information, and then all it'll see is like 6 or 8 little markers. That's all it'll see, little dots. And then the double scan, the second scan, is the surgical scan appliance all by itself. And again, really, it sees the plow, sees the markers, and then in the software, it'll mesh those markers up, and then it'll magically place that denture in the patient's mouth so that we have that information to plan off of. So the biggest thing is that for a partially edentulous case, the scans can be done at either time, but for a fully edentulous case, please make sure that you have a scan appliance in the patient's mouth to do it. Otherwise, the scan is pretty well useless, other than, yes, we can tell you if implants can be placed, but we have no information on the VDO. We have no information on where the implants are going to be placed in relation to the occlusal arch and all that stuff. So it's kind of pretty well a waste. So we'll just go through a couple case studies here to show you kind of the power of the software. So it happened to be a complete upper case in a 5-unit lower case. It happened to be done by a surgeon, but this is a case where it could have been done by a GP. And for those GPs who place, this would typically be a case where, it's a little big for my liking. As a GP who places, I think I'm going to refer this one off, which is great. Nothing wrong with referring, obviously. There's the surgeons do a fantastic job, and definitely some cases should be referred. But I think the GPs who started using CBCTs, they found that they can do a few more cases in-house than they might not have been able to before. So, and we'll see when we break down this case, it's really very simple. So, put yourself in the GP's mind, and we're going through this plan. We can see when we do the cross sections of each tooth, that implant is, boom, slam dunk right in there perfectly. We know the nerve, we're far away from the nerve. There's no surprises here. Again, nerve coming out prosthetically, perfect, tons of bone, we're good. So when we keep going through the slices, when you break it down, this 5-unit case is really just 5, I'll say simple units, right? Which makes it more doable for a GP. And on top of that, even if it does get referred, the surgeons, very much like having these guides, because it makes the surgery a lot easier and it makes it a lot quicker, which is great. The sooner we can get the patient in and out of the chair, the better, right? So this is a case, that same case, but this unit here, this pontic was being sectioned off the bridge. But this is a case I know for sure that if you send this model to your lab, us included, and you were asking me to section this pontic off, I'm never going to put the implant in that angle. I'm not going to do it. I'm going to put it straight up and down according to this tooth and this tooth. So this is a prime example of where doing a guide chair side or lab side or clinical side, the hole's in the wrong spot. It's useless. And so most surgeons tell me most of the analog guides that we all get, that we make, half of them go in the garbage right away. So half of those guides that you're spending $80, $100 on are never even used. They're garbage. Worst case scenario with this one is if we, which I believe most of us would have, put the hole straight up and down, we're getting desperately close to hitting that root. So, damage can be done by using these with all good intentions, but this is something that probably never would have been picked up without the CBCT. So any kind of save we can make on that is fantastic. And again, this is another illustration. So this case shows a lot of different advantages to the software. This is a case where we tried to put 2 implants in, 2 3.0 side by side. They wouldn't fit. This happens to be a 3.5 millimeter implant, and you can tell there's no room to put 2 side by side. So this was a case where we decided to do 2 units off of 1 implant, which we do a lot of the time. There's nothing wrong with it at all. The main advantage of using the software is that you're having that conversation with the patient beforehand, so they know, they make the decision on this, not 4 months later after these implants are integrated saying, oh, by the way, Mrs. Smith, we're doing 2 implants off this one, 2 crowns off this 1 implant. Yeah, you're going to have, yes, you're going to have to floss on either side, and yes, there's an implant in the middle. Those conversations should never be had after the fact. They should always be had ahead of the fact. That's why I love the power of the software so much, is it allows you to have that conversation with the patient. My dentist friend, Jim McKee, he always says this, and it stuck with me, is that, you always want to have those conversations. Is it going to change the outcome? No, but it will change the conversation. So the patient's going to know ahead of time that when it comes 4 months down the road to take that impression, oh yeah, doc, I remember you telling me that it was going to be two units hanging off that one implant. Yeah, great, perfect. I'm glad everything went well. Because remember, as GPs, the trust the patient has in you is everything, right? You always want to overpromise and underdeliver, right, as they say. So all these conversations you can have up front to reduce the surprises in the end is going to boost your emotional bank account or your trust, if you will, with your patient. So the minute you start backpedaling with the patient is never a good thing, and that's a quick way to start losing some patients. So it definitely gives you better conversations to be had at the beginning. So this is an example of the guide, which it comes back. This, again, just happens to be a pilot guide. And then we see the surgery here. So again, this was done by a surgeon. It happened to be an upper all-on-5 on the same day. It was good morning. We happened to go back and convert the upper denture, and everything was great. So, but you can see, the positions mimic the plan perfectly. So, and the surgeon had this guide in for literally a minute and a half. That was it. 5 pilot holes drilled, and the guide was in and out. And then, and then we flapped the patient and put the implants in. But it does decrease the time, especially on cases like this, even single cases or double units. But on a case like this, if you can save 15 minutes off this appointment, that's great, right? If I'm a patient, I want to be out of there 15 minutes ahead of time, especially, you're doing the upper conversion. Every 15 minutes is more swelling that's going to happen. So time is everything in these surgeries. Also, for overdentures, some people don't think it's all that important for overdentures, but planning these cases for overdentures is critically important. You can see down below how parallel these implants are. For those of you who have had locators, or I know Ben was talking about Novolocks earlier, same thing in terms of wear. The less parallel these cases are, the more often those patients are going to be in your chair asking to get those inserts replaced. So it's very, very critical to have these as parallel as possible. And the planning on the software can make that happen. So I'll just go through, I know we're running out of time here, but we'll just go through a treatment plan case. So this is a typical treatment plan that we would use for a double scan. We have the denture scanned, and then we'll initially, option 1, we'll set this up for a locator case. So, I've got them as close to parallel as I think it's possible, but even now I'm going to send this off to the surgeon to say, hey, what do you think of this? So we can see as we go through the cross sections, they're definitely not ideally placed, on the buckle, it's getting a little bit shady on the bone. You know what I mean? As I go through these, I'm like, yeah, the surgeon may be able to do these, but it's definitely not ideal. That one's obviously ideal. The rest are kind of taken off of that one. So, surgically, some surgeons may say, yeah, I could do that. But then when I look further, look at the spread on that. It's just not ideal for a locator case, right? Anytime I do any kind of case like this, we always want symmetry, right? If it's a locator case, whether it's an all-on-4 surgery, we want to have the implants as symmetrical as possible. It'll give you, engineering-wise or structural-wise, it'll give you the best long-term outcome. So when I look at this, spread-wise for a locator case, it's just not ideal. So already in my treatment plan, I'm like, this is not necessarily a great locator case. Now I've modified them so a little more surgically, they're more ideal. They're right in the middle of the bone. And I thought, well, maybe we can do a 15-degree angle correction and still get away with locators, knowing that the implants are in the right surgical position. We can get them in the proper prosthetic position. Sorry, the locators in the perfect position. And knowing that we could always, send a true abutment and get in any amount of angle correction as possible with locators nowadays. But still, it was the spread that really was not good. For a locator case, this is not the best case for any kind of attachment, in my opinion. So then we went to the all-on-4. Maybe they're an all-on-4 candidate. So the beauty of this is that once we have that double scan, guys, we can really determine everything. A double scan and a set of pictures, and we can literally treatment plan that case. We don't really need anything else. So now we go through the all-on-4, 5 or 6 or whatever, however many implants you prefer. And we can go through the cross sections. We can see here now, we're back to the molar on this because of the angle. We have the multi-units on there. We have the temporary cylinders on here. We can see how we're going to go. And, making sure that I have maximum spread of the implants, whenever I plan all-on-4, cases, I like to think of it as a chair, legs on a chair, right? You want to get those implants as spread out as far as possible to the corners of the mouth to give it the most stability. So this happened to be a, yeah, we ended up going with an all-on-4 on this. The only thing that really struck me at this point was the flange. Anytime you're going to plan a fixed case, obviously the flange is always one of the major considerations. We can see where the temporary cylinders are going to come out. So it helps us when we make the conversion denture where the holes are going to come out. And sometimes we can get fixed, right? We don't know, especially when I go through the cross sections. So if I go back, cross section of this tooth here, that's a pretty, the decent sized flange. So we're like, are we going to be able to do this? One quick and easy way to find out is you literally just cut the flange off. The duplicate denture, if you've had the scan appliance done, it's easy to just cut the flange off this duplicate denture, and you just literally try in their mouth. In 5 seconds if that patient can needs or does not need a flange. Their upper lip is either going to cave right in, or it's going to be just fine. So it's a pretty easy diagnostic tool to find out. So again, we ended up going with full arch fixed on that case. Because we could determine the VDO, we could determine everything we needed just by that double scan. So very, very powerful to go through the treatment plans with your patient. One thing I will say is never promise your patient anything in the beginning. I would tell them that you're going to treatment plan the case, and then you'll go back with options. Because a lot of people, come in nowadays and say, oh, I want, what I saw on the commercial, I want a fixed da-da-da. And some dentists get into trouble saying, oh, yeah, we can do that for you. Well, you don't know until you know, right? So I would hold off on promising them anything until you go through the treatment plan, and then you have that conversation and let them know what their options are. But I think the important thing is this isn't for only large cases, right? We all know that, these large cases are great, and, we all love doing them and splashing them around Instagram and all that stuff. But, most dentists are doing single units, double units at a time. So I think the consensus or the thought out there is that, CBCT guides, they're only for big cases. Well, no, that's not true. Actually, there's been, again, over 2,000 cases that I've gone through. I feel like I've dodged the most bullets out of the singles or the double implants, right? So this was a case for an implant in the 4 or 5 area, seemingly, slam dunk case. Yeah, there's obviously some bone loss on the buccal. But we'd probably get it in there. So I think without this, the surgeon's going to say, yeah, I can get an implant in there, no problem, which they can, right? We do the cross section there. We can get an implant in there. Then we do the wax up in there, and our heads start to, I don't know if we can or not. So surgically, implants in there, no problem. So I think traditionally a surgeon or a GP would have placed an implant in there because that's where the bone was, and it can fit, right? The implant can fit fine, right? From a surgical point of view, done, implants in. The problem is, from a restorative point of view, the general practitioner's view, and in the end, the patient's view is, look where this is coming out. There's no leeway here to angle that implant anywhere else. It's coming way out of the lingual, right? And when you look at it this way, this is going to be massively bulbous on the lingual here, right? Because remember, this is the screw hole. We have to make this crown almost come out to here to have the strength to make it strong enough here, right? So this crown almost has to come out like this when we're done with it. So this would have been a case where that we would have put the implant in. We would have got the impression, we would have started the case, and we would have been like, oh man, this is going to be bulky. The dentist would have put it in, and the patient would have been like, what the heck is this? I feel like I have something stuck in my mouth forever. And the patient would have hated it, guaranteed. And they would have hated the dentist, and they would have, not really the lab, but they would have hated the dentist. But yeah, so it's a prime example of a simple case, having that conversation ahead of time of the patient to saying, you know what, your options are a bone graft on the buccal, which I think most of us would agree that probably not going to happen. In this case, it happened to be a 3-unit bridge. So, I'm a huge implant proponent, but there is a time and a place for a 3-unit bridge, and this happened to be a case in this instance for the patient and the doctor. So again, having that conversation before really builds the trust with your patients, not after, right? As soon as you put that crown in or take the impression to get the heads up that it's not going to work out, you're backpedaling and you're going to lose trust with your patient. So really, really important. 2 more quick things and I'm done. And that, again, very similar kind of case. Lots of bone on the buccal, though. This wasn't the issue in this case. The problem was the implant was placed at the crest of bone, which most of them are. So this one was not planned on CBCT, by the way. But if it had been planned on CBCT, we would have seen the future result. and known that this wasn't going to be ideal. So, the doctor got this in and the patient complained about it. Of course they complained about it. We all would complain about having this in the mouth. The problem is at this point is it's really hard to fix besides doing something like this. This is what the doctor wanted. This is what the patient wanted. This is not an ideal situation. So this is something that, we didn't really want to do, but, at that point, the option was taking the implant out, which was just not going to happen. So we ended up doing a ridge lap. Again, not hygienic. Luckily, this patient has pristine hygiene, and this is just a photo from the doctor that he sent in, I don't know, 6 months after the fact. So, it works. It definitely looks better. But again, that ridge lap is really going to be something that we're going to have to keep a handle on over the next few months and years. So again, if this case had been CBCT guided, it would have been something that we picked up on in the beginning and not had to have this awkward conversation with the patient at the end. So CBCT planning, in my opinion, is definitely becoming the standard of care in the implant dentistry. And I think once you inquire a little more or really think about it, for the cost and the amount of time that's going to take you, which is almost none, I think it's something that would really help, build the trust in your patients and let you have a more successful implant practice for sure. So that's all I have for today. Hopefully it was a little bit eye-opening for some people. If there's any questions, just fire them out right now. And I have my email there too. So if you have any questions after the fact, just please feel free to email me. And if there's something that we can help you out with, great. And if it's something that you want me to help you out with your lab that you're currently working on, we can help that out too. So we're just here to help and hopefully get the better implant restorations for your patients. So thank you very much.
Sweet, Christian. Thanks for that. I think Zayad's coming on too. I think I'm going to do the housekeeping. Big thank you for Christian Hall and Ben Mueller. Oh my God, I got paint stains all over my scrubs. Good Lord. But did you want to do the housekeeping, Zayad, or do you want me to do it?
No, just is there any questions? No, like you've done a great talk. There wasn't much questions. I think you've covered everything pretty well there.
I think one of the questions, Christian, like the major questions was like, there's a lot of young dentists in the audience, and like what you showed can be really overwhelming. I know you're really in touch with the school at Dalhousie on the East Coast. I think can you just give in touch, like if a young dentist were to start, like some guidance on where to start, what resources to go and look into. Obviously, like you said, maybe start with single unit dentistry, but just some guidance, because I know you're a really proponent of education as well on your side.
Yeah, absolutely. Yeah, I would just, first and foremost, honestly, just talk to your lab. Your lab would probably know some stuff. They would have the resources locally of where you can go. But yeah, any kind of course, definitely take, an implant course. And again, you're going to find out from the implant course that you go on kind of what they would recommend. Or yeah, just call your local lab and they'll help you out. And just find all the resources you can. You can always reach out to me, and I'm here to help any way I can. But it's really simple. I not to dumb it down, but literally, if you want to start with a single slam dunk implant case, you get the CBCT done, you send the models, we go through it together. And sometimes, over 2,000 plans that have gone through, it's only about 1,000 guides that we've printed or had done. And 1,000 of those, the other 1,000 are basically cases that we've gone through in the beginning and said, nope, this is definitely not an implant case. And it's a case where, it's an upper 6, there's, 12 millimeters wide bone, and it's a slam dunk case, right? So we don't even get a guide done. So I don't want people to think that, if I get a CBCT in models, I have to get this guide. No, it's going to cost so much money. I know in our lab, we get these cases, we go through them all the time. We plan them, we share them with the doctor, and the doctor says, it's a slam dunk. I don't need a guide, but thanks a lot. Then it's right. Great. Awesome. Good job. Have it. And there's no charge. There's no nothing. So it's literally as easy as just getting a CBCT, getting a model, going through the plan virtually, especially when you're new. I find like a lot of people, they'll go on an implant course. They won't place an implant. They're still scared. So I find that the CBCT guides are a great way to kind of nudge them along and give them that confidence to put that first implant in, put that second, third, fourth one in. So once you see it on the software, it really does give you the confidence. So it's just as easy as getting a CBCT, honestly.
And then another question that's out there is, like a lot of the prior lecturers have spoken about intraoral scanning. I know you're a proponent. You have multiple systems in your lab. 3Shape is one of them, and you're digital ready. You know,
Yeah.
I know a lot of dentists are talking about single unit dentistry and chairside dentistry with their intraoral scanners, but I think, you know, communication is a big tool. So would you recommend the standard of care? I know you were recommending that CBCT guides are the standard of care in your humble opinion, but would you also proponent that like owning a intraoral scanner in correlation with a CBCT scan will be the standard of care as well?
Yeah, I think so too. And it's, you know, I know everyone's, you know, COVID-19, they're all, you know, everyone's knee-jerk reaction and how, you know, crazy this is, and, you know, what are we going to do, and all these guidelines coming down. And I think intraoral scanners are definitely, I know some intraoral scanners come to dentists and saying you get a scanner or else, which is not true. But I think we can all agree that using intraoral scanner definitely does, it can cut down on some cross infection for sure. I mean, that's a no-brainer. Is it absolutely necessary? No, but I think, you know, if you're a young dentist starting out, what I say to my young dentists is you're going to have an intraoral scanner before you retire, for sure. You're not going to go through a 40-year career now and not have one. So no time like the present, right? Just get it, get on board with it, right? So I would say, having said that, I think, not that I think it's absolutely necessary because of COVID-19, but I think we are going to see in the next couple of years a huge upswing on the adoption of intraoral scanners, just because of this. And I think people are just, because, you know, there's so many people like on the fence right now, just like there was years ago with CEREC. Should I get it? Should I not get it? There's so many people on the fence. I think this is going to, you know, tilt a lot of people over. So long story short, yeah, I think iOS in conjunction with CBCT would be a great idea.
And I'm going to pipe in here just for a second, Christian.
Yeah.
Great job. I'm obviously also a big proponent of the intraoral scanners. Yeah. I was a CEREC doctor, been a CEREC doctor for over 10 years. But you know what we talk about, I agree with what you said 100%. I mean, you are going to need one at some point. You are going to have one. So why not be, you know, we think about the adoption of things on the market, and there's a bell curve. Why not be one of the ones on the early part of the curve where you say, well, I got it because it was a fantastic thing and I was an early adopter, instead of getting it because everybody else has it. And I would go so far, again, I agreed with what you said in terms of the standard of care. I would go so far as to say, really having a CBCT is pretty much the standard of care for implants now. It will be the point. If you don't have a CBCT and something goes wrong and the RCDSO or whatever governing body comes after you, if you have that, even if and you don't have to have a guide, again, same thing with Christian. I do a lot of CBCTs, and that gives me a ton of information. I can design it and know exactly what size, what length of implant I'm going to place there. And I don't care to use the guide at all because I know exactly what I'm doing, but I know my parameters and say, I can fit this size of implant in there and this length, and then you're good to go. But you don't need a guide. A guide is great. And Christian, you really covered that in so many great ways in terms of just using the pilot guide or using full guidance. And so fantastic. I think you did a great job covering all the different options. And I agree with everything you had to say, but certainly really strongly agree with the technology is going to be, and not going to be, but almost to the point where it is the standard of care. So you may as well, do your research and get in earlier than later. And also, guess what? It's not going to get any cheaper either.
No, it's not. I think that's what a lot of people are waiting for. Oh, it'll be cheaper in 5 years. No, it won't.
No, not at all.
No, it won't.
All right, buddy. I think for questions, I think if you guys have any more questions, just post them in the chat and we'll answer them in an email. And I think Zayad's going to take it home.
Yeah, Christian, that was amazing. There's a lot of amazing concepts, especially for us young dentists as well. So I appreciate that. Thank you so much for that talk. Friendly reminder for our upcoming talks on Thursday, May 14th with Jason Adenada and Dr. Gordon Shi. These guys are amazing, and I'm really excited for their talks. So it's going to be followed up by Friday's presentation on treatment planning of the Warren Dentition by Dr. Neda Al-Batish. If you haven't done so, make sure you register at dtacademy.ca. We'd like to thank our co-hosts as well, Dr. Jeff Sumner and Mark Chan, along with our speakers, Mr. Ben Mueller and Christian Hall, for such a wonderful presentation. So thank you, everybody, for joining us, and I would look forward to seeing you tomorrow at 11 a.m.
Great.
See ya, guys.
Thanks, guys. Great job.
Awesome.
Take care.